Okay, well, hello everyone, and thank you for joining AVAC and the American Sexual Health Association, ASHA, for our webinar today focused on syphilis and how the U.S. National Syphilis and Congenital Syphilis Syndemic Federal Task Force is responding to rising rates. Our speakers include Kate Miele and Neelam Gazarian. Their bios will be available in the chat. And I just want you all to know that I practice saying their names, but once I go live, I get really nervous. I still butchered it. So apologies to both Kay and Nellie. This webinar will be recorded and the recording will be available later this week along with the slides being presented today. If you have any questions during the presentation, please feel free to put them in the Q&A box or within the chat and we will get to them at the end of the session. And with this, I hand things over to Kate and just thank you so much, Kate and Nellie, for presenting today.
Of course, we're so happy to be here, y'all. Thank you so much to both of your organizations for hosting us and to everyone who joined us today. We're just so thrilled that syphilis is finally getting the attention that it certainly deserves. So Nellie and I are going to present today on syphilis in the United States, the current state of the epidemic, and how it is being addressed. These findings are ours and do not necessarily represent the opinions of our institutions. I would like to mention in particular, because both Nellie and I are federal government employees, that we all have to be aware, especially when we're talking about syphilis, that there is a deep-rooted mistrust in the medical and public health establishments. And a lot of this is attributable to the U.S. Public Health Service syphilis study at Tuskegee. And it's particularly important for us to think about this in the context of our work. The study occurred from 1932 to 1972. And as you know, it followed the natural history of syphilis. It did not offer participants the opportunity to consent, nor did it offer treatment even after it was widely available. And 2022 marked the 50th anniversary of the end of the Tuskegee syphilis study. And so we all just need to be aware of the context in which we are talking about this very important infection and to recognize the deep rooted mistrust and the human rights violations that occurred. So with that context and with that in mind, we also would like to go through a few language disclaimers. So I know that everyone on this call knows, but just to reinforce that race and ethnicity are social rather than biological constructs. And so when we're talking about that data, it is a reflection of systemic racism and the experience of racism. Any differences are not biological in etiology. Pregnant people and birthing parent are used throughout to denote persons who have or who are pregnant. And whenever we use maternal as an adjective, it should be understood to denote features of the birthing parent agnostic to the gender, gender identity, parenting intention, or parenting identity. And now onto our talk. So we're going to start with syphilis by the numbers. We'll get into a little bit about prevention and the federal response to syphilis. So just a little bit of background. So why are we all here today? We're here because syphilis is a sexually transmitted infection that can lead to serious health problems without treatment. You know that syphilis can be transmitted by direct contact with a syphilitic lesion during vaginal, anal, or oral sex, and of course, transplacentally to the fetus. Very rarely is it transmitted by touching infectious lesions or through blood transfusions. Importantly, there are really significant complications from untreated syphilis. So the first category is that of neurosyphilis, ocular syphilis, which is the eyes, otosyphilis, which is the ears, and these include things like stroke, meningitis, blindness, and hearing loss. And then, of course, there's congenital syphilis, which can lead to stillbirth, neonatal sepsis, preterm delivery, and miscarriage, and increased HIV acquisition and transmission. But the important thing to remember is that congenital syphilis and all of these sequelae can be prevented by treatment. And so in particular for congenital syphilis, it can be prevented by diagnosing and treating syphilis prior to pregnancy and diagnosing and treating syphilis more than 30 days before delivery. So let's take a look at the numbers so we can understand the context of what we're talking about. So syphilis rates are increasing across the United States, which is, I know, why everyone's on this call. In 2022, there were over 200,000 total cases of syphilis. The primary and secondary syphilis rates, which are the most infectious stages and often the leading edge of infectious disease epidemics, increased by over 200% over just 10 years. And as you can see by comparing these two maps, the lighter colors indicate jurisdictions with low syphilis prevalence, and the darker colors indicate jurisdictions with higher syphilis prevalence. And you can obviously tell that now we're seeing syphilis everywhere. From 2021 to 2022, so over just 1 year, the rate of reported primary and secondary syphilis among women increased 3 times more than the rate among men. So as you can see along the side, the rate of men increased by 44% and the rate in women increased by 190%. Mind-blowing. And over 10 years, the primary and secondary syphilis rate among women increased by 867%. And then a lot of people ask us about risk factors for primary and secondary syphilis, and so I wanted to show you this slide. And what this shows us is that if we look over time, these specific behaviors along the right-hand side, sex with anonymous partners, sex while intoxicated or high, sex with people with intravenous drug use, or exchanging sex for drugs or money, we don't see any huge increases in any one of these categories. In fact, we really see a leveling out. And what that tells us is that there's no particular behavior that is driving our increases in syphilis. And then if we zoom in on the substance use data, we see the same thing. We see that methamphetamine and injection drugs are certainly associated with syphilis infections, but there's no particular rise over time in any of these. And what that reinforces for us is that syphilis and our current crisis in syphilis is really about sexual networks. There is simply more syphilis in heterosexual communities, and anyone who's having sex in a community with a lot of syphilis is at risk for syphilis. So let's take a look at our congenital syphilis numbers. Now, when we compare these two maps, again, the same colors are used for my earlier maps, from 2013 to 2022, what you can see is that congenital syphilis cases increased by 937% over just 10 years. And what this means is that when we zoom in and think about the data that I presented previously, along with the congenital syphilis data, you can see that there are parallel rises. So the black line here is the rise of primary and secondary syphilis among reproductive age females, and the blue bars are their congenital syphilis cases. And you can see that they were rising together. And in 2022, there were a total of 3,755 cases of congenital syphilis reported, which again is that 937% increase from 2013. The highest number of reported cases of congenital syphilis in 2022 was among birthing people who were non-Hispanic, Black, or African American, with 1,122 cases. But the highest rates of congenital syphilis in 2022 were among birthing people who were identified as non-Hispanic, American Indian, or Alaska Native. Now, I know these numbers are kind of hard to contextualize, so we put on this slide the cases per live births in 2022, which I think is really helpful. So if you think about this, what this tells us along the right of this slide is that 1 in 155 live births in 2022 among people who are American Indian or Native Alaskan were impacted by congenital syphilis, which is just, again, a staggering statistic to think about. I'm going to let you think about it for a second. Pause. Thanks. And in 2022, what this means is that there were 282 congenital syphilis-related losses, a 24% increase from 2021. And this includes 51 infant deaths and 231 stillbirths. Now, as was mentioned, I'm an obstetrician gynecologist, and so I'm the person who takes care of patients when these devastating outcomes occur. I'm the person who talks to them about their new syphilis diagnosis in the context of these horrible pregnancy outcomes. And this is something that we all need to rally together around to stop. And what we also know from our data is that when we look at the cases of congenital syphilis and we looked at the missed opportunities for prevention, timely syphilis testing and treatment during pregnancy could have prevented almost 90% of congenital syphilis cases. So that's what we all need to do together, and that's why we're here today. I'm now going to pass it over to Nellie, who's going to talk a little bit about what the federal government is doing to respond to syphilis. Thanks, Nellie.
Thank you, Kate. And indeed, very sad reality that we're in right now to talk about syphilis, congenital syphilis cases. Next slide. click one more time for me. So real quick, we just wanted to highlight a few things that have been happening in the federal space, right? Now, this is before I will jump into the task force, but the first ever national strategic plan, STI strategic plan, was released. It expands up to 2025. So if you're paying attention, you know there should be a new one coming soon. CDC's call to action. This was updated back in 2016, 2017, around that time, that specifically focused on what are some of the actions we could take because of the rising cases of syphilis. Then NASIM soon after came out with their STI report. And then, of course, we released specifically the STI federal implementation plan as well. So now there's a lot of syphilis components in all of these. So I just want to highlight certain resources already exist out there for you to go in and look into. Next slide. So what happened? Why is there now a task force? Well, as you heard from Kate early on, we had the epidemic under control way back in the day, and now we are still here. You all have seen reports of, to put it bluntly, babies dying. And as Kate mentioned, she's one of those folks that is giving that diagnosis, has to deal with this every day. So we knew we had to do something about this particular crisis in our country. Next slide. And here comes and we have an internal joke. It's called the National Syphilis and Congenital Syphilis Syndemic Federal Task Force. Say it 3 times and you win a prize. So whoever can say it 3 times, you get to ask us an extra question at the end at the Q&A session. No, I'm kidding, but really this sort of started back in, I will say, 2023. Around May is when we started to hear in the very first time at the STI Federal Implementation Work Group meeting. So this is your usual business as usual STI group that meets to talk about the STI Federal Implementation Plan and the strategic plans that I shared early on, where for the very first time, Indian Health Service talked about the disproportionate impact of syphilis, congenital syphilis within their Native American communities. From there on, we heard from our state health officials. Admiral Levine heard directly about issues of shortages with bicillin and other issues that may impact the syphilis crisis in our country. Then we moved on and we moved to PACHA in June of 2023, which is the Presidential Advisory Council on HIV/AIDS that advises the secretary to think through HIV and its syndemic and what makes recommendations and passes resolutions. So they passed an urgent resolution regarding syphilis. One of the very first things they mentioned was to establish what we now call the National Syphilis, Congenital Syphilis Syndemic Federal Task Force. I can show off. But overall, no, go back one more, Kate. Overall, the group is really focused on achieving its goals to ensure that all federal partners are at the table. The task force is focused on reducing primary, secondary syphilis and congenital syphilis rates, and particularly from that health disparity lens in the U.S. And you can see specifically our goal here to increase cases averted by 5% of congenital syphilis by September 2024. Next slide. Overall, the task force is chaired by Admiral Levine. Early on in May, we gathered a lot of the agency leadership to talk through this particular crisis, and everyone agreed an urgent action needs to be taken. And hence the establishment of the federal task force. It comprises of 10 different HHS agencies, and it has departments across the federal government as well. That includes DOJ, DOD, others as well. So it has overall 200 and close to about 250 federal members that serve on the federal task force, and we will get into the cadence of how often we meet in the next slide. Oh, I jumped ahead, not yet the cadence, but our framework that we focus on for the task force is centered around health equity. We know, similar to many epidemics, that we are seeing this disproportionate impact among STIs as well. One of the very first ones that sounded the alarm were Native American communities. And we go into our non-Hispanic African American communities and Hispanic community as well to see that there is that disproportionate impact there. So health equity is at the center of this framework. And our pillars focus on data surveillance, prevent, screen, diagnose, and treat. However, the bulk of the work happens in those 6 subcommittees at the bottom. So you have data and surveillance to strengthen our data surveillance systems, prevent, screen, diagnose, treat, a particular focus on congenital syphilis. And thank you, Kate. Kate is our co-chair on that particular subcommittee. Equity and Syndemic. Equity and Syndemic is in fact having their webinar today at 2 p.m. I'll be sure to share it in the chat. And the Communications Community Engagement Subcommittees. Particular composition of these subcommittees is that the co-chairs that are leading these subcommittees are from different agencies. So for example, Kate is from CDC. On her particular subcommittee, we also have someone from the Office of Women's Health at the Office of the Assistant Secretary for Health, which is OASH, where I am, that they chair that subcommittee together. Prevent, Screen, Diagnose has folks from CDC, and then it has folks from HRSA, which is the Maternal Child Health Bureau, as well as HRSA HAB, which is the HIV/AIDS Bureau. So you'll see that across the board, the subcommittees, we are intentional in making sure it's representative of various agencies that are on this particular task force. Next slide. So here are the co-chairs that I listed early on, and a huge shout out to Kate. She's always available to co-present with us to talk about our work and her work as well. But overall, this is the composition of our subcommittees. And a lot of agencies that might not be serving as co-chairs still serve in various subcommittees. So you'll see across the board, there's about 150 or so members across 6 different subcommittees from multiple agencies. Next slide. So now that we have the composition out, what are some first priorities that we wanted to tackle? The first one was, are there certain areas that we need to focus our efforts on to identify, are there any priority areas? You'll see some of us on the call who do some HIV work as well, in addition to our STI work, will know this is sort of looking at how EHE looked at where the regions are. Is there traditional hotspots? Although I don't like to use that word, but we looked at the areas where we should focus on. We also look at programmatic policy procedural actions that the federal government can take. Are there certain barriers that we can help eliminate that are, I don't, again, like to use low-hanging fruit, but low-hanging fruits that we could take care of. And overall, we know that increasing community engagement and public awareness has been a crucial issue that we've heard on multiple different conversations that we've had with you, external partners, as well as internally. Next slide. So to overall go into our operational functions, we meet regularly. We used to meet bi-weekly, and now we meet weekly. There are agency leadership on the call, and there's also subcommittees on the call. That's where the rubber meets the road, is what I say. They share best practices. We want to really, the whole point is to coordinate our resources. As you all know, CDC is the one agency that's funded for STI work, and others don't quite get a line item or funding for STIs. We know we cannot solve this issue because it is a syndemic issue. So where can we all push? Where can we all come together, coordinate our efforts and resources, and what can we all collectively do to help with this crisis? So we looked at existing resources. Where can we push? We identify some priority communities that we need to focus on. And then what were the agencies that really have a role to play here? DOD, USDA, they're all on the table to ensure everyone who has a role to play is on the table. Next slide. This is how we went about it. We, the Data and Surveillance Subcommittee, a huge shout out to IHS and CDC co-chairs for bringing this together, looked at where are areas that we really have to focus our efforts on. Knowing that the resources are limited, we want to see where particularly we should focus our efforts. That doesn't mean we're not focusing our efforts in the other states. We're still continuing our work, but we're trying to provide enhanced resources if we can in these particular states. My geography is really bad, so I can share a link about where these states are, but you'll see some are highlighted. How did these states make I call them the 14, there's 14 states. How did they make it? It's written out here in the key. Some states qualified based on rates and counts, some based on their high rates, and some qualified based on their counts only. I will add that because of census, we wanted to ensure that there's representation from all U.S. Census Bureau, so New York State was also added in. Overall, in these jurisdictions, they account for 57% of primary and secondary syphilis cases and close to 74% of congenital syphilis cases. That's a lot of cases within these 14 states. So we're just following where the data leads us, trying to make sure that we're providing resources to these states. Enhanced resources and technical assistance and other places we can go in. One thing that I want to highlight, and I'll just take one example here, is within these states, you will see that it represents 65% of primary, secondary syphilis cases and over 70% of congenital syphilis cases among non-Hispanic American Indian Alaska Native individuals. And you'll see the breakdown of different races. So we wanted to ensure that we had the equity lens, and hence we looked at specifically the cases among these particular populations as well. Next slide. We sat down, particularly within our Prevent, Screen, and Diagnose subcommittee, and looked at, so where is it that we should focus? What are the priority populations that we should be focusing on? And here is a list of our priority populations. I'll just highlight a few. We have the racial ethnic minority populations that Kate, shared that data early on as well to think about. We want to prioritize them. Justice involved people, as well as people who use substances. We've heard in a lot of these places that people who use substances is one of the key issues in driving factors of the syphilis epidemic, as Kate shared earlier as well. So here's just a list of our priority populations. Next slide. So what have we seriously been up to in July? So July, we looked at HRSA and IHS. They issued a letter to the grantee to provide informational resources, particularly highlighting that specifically within the Native American community, the epidemic of syphilis, congenital syphilis. Moving through this time, I'm not going to read them all, but CDC published draft guidelines for doxycycline that you all may have had a chance to provide comments on. IHS also announced a National Clinical Strategic Initiative and released the STI treatment guidance. One thing that I know was the buzz around was the generated heat maps for priority jurisdictions. So we worked with the priority jurisdictions and overlaid syphilis, available federal syphilis resources with the cases. So it's like a heat map that shows you where your federal resources are based on the cases. And I know that that's something that the states have really liked. And that's something that we've shared with them. Next slide. Running through really quickly the big ones here. I wanted to share that extensiline was there was a temporary waiver for importation of extensiline to address the bicillin shortage. Equity workshops were held back in January, which was the American Indian Alaska Native was the first one that we focused on. And the next one was a national effort. The one webinar that you hear about today is sort of the follow-up from the Equity and Syndemic subcommittee. NIH has also been looking at this from a research perspective. Since bicillin is our only option, are there other alternative treatments out there that can help with this? So that's one. HHS and CDC also co-hosted a provider roundtable in February that was led by Admiral Levine and Admiral Merman as well from CDC to talk about congenital syphilis. So there was about 12 or 13 national provider organizations as well on that particular roundtable. Moving forward, we're continuing to provide those funding flexibilities. There's a lot of funding flexibilities that agencies have provided, including SAMHSA, IHS, HRSA, particularly Title V, and there will be some listed in our resources as well that go in specifically to talk about STI services that you can use if you're a part of the grantee network. Next slide. So here are some areas that we heard overall. What are the key issues we should be focusing on? When we did our equity workshops early on in January, then we did our provider roundtables. We also met with each of those 14 jurisdictions individually to learn directly from them what are those key issues we should be focusing on. Not to our surprise, but provider education and training was one big one. So thankful to ASHA and AVAC for inviting us here today to talk about these issues overall. Public awareness is another big one. That when you go in, and I talk to my friends and I talk about syphilis all the time, the first thing they say is that still really an issue? And I was like, yes, it very much is. And then information sharing on best practices. When we talked to the jurisdictions, when we had the equity workshops, we heard a lot of chatter in the chat, or that they were thirsty really to learn from each other. So that's something on our radar as well. Can we do some sort of a learning collaborative between the various grantees, between the various jurisdictions? Next slide. Overall, nicely, just to highlight some of the successes we've had is to have these briefings with external partners, collaborations. So thank you again for inviting us today. The temporary importation of extensiline, recognizing that we still have a lot of work to do. Workshops is something we've done, and the continued funding flexibility. So just want to highlight overall, there's some of our major successes to date. Next slide. What are our next steps? We're always looking forward. What are things we could be doing more? Awareness is an issue that we want to continuously work on. Training healthcare workforce is another one. Issuing point of care testing. I know that we've had this ask from a lot of jurisdictions that there are point of care tests available out there, but what are some considerations that everyone should be considering? So that's in process right now. We're looking at a healthcare provider campaign. Is there something that we can look into to see how this may serve across HHS to highlight? And then continue to strengthen our external partnerships to address congenital syphilis and others. And hot off the press, this is something that we wanted to highlight is the expected summer 2024, the doxycycline for PEP, specifically for syphilis guidance, will be coming out as well. Next slide. So now we all wanted to end on a positive note, Kate. So Kate, I'll turn it back over to Kate to see what can you do today to help stop syphilis and prevent congenital syphilis? Kate, back over to you.
Absolutely. So I'm going to kind of synthesize everything that Nellie presented to talk about the framework that we're using for how we think about how to stop syphilis and prevent congenital syphilis. But before I do so, I just want to acknowledge that syphilis is an infection from the early 1900s, and we're still using tests and treatments from that same era. And we know that we need a lot of research and development in this space. We need new tests that are better and easier to interpret. We need alternative treatments. And Caro Johnson, I'm just going to answer your question from the chat right now. We need a better way to get people access to prenatal care and to high quality prenatal care. And those are separate issues that are going to take many years to move forward with. So for right now, these are the 4 areas that we're focusing on. All right, so here we go, everybody. But before we get there, I just want to reinforce what we all know, and that's that congenital syphilis has significant public health implications. We know that babies are dying and facing lifelong impacts. And when we think about those numbers that I presented earlier, with about 282 syphilitic-related deaths among both infant deaths and stillbirths, what that equates to is about 12 kindergarten classrooms of kids who will never be part of their families, who will never make contributions to our country in the United States alone. And those are tremendous losses for us. We also need to think about the cost of managing congenital syphilis, which is more than that of screening and treating someone during pregnancy. And then something that all of us on this call know, congenital syphilis really is a reflection of inadequate healthcare access across the country and devastating health inequities. So that's the framework that we'll use for thinking about our strategies. So these are the 4 strategies, kind of 4 pieces of the puzzle is how I think about them. So 1, we need to be screening and treating sexually active people. 2, we need to be screening and treating people who are pregnant. 3, we need expanded screening in non-traditional venues. And 4, we need education, training, and surveillance. So let's dig in on each of these. So 1, screening and treating of sexually active people. So this is what y'all are involved with every day. If somebody is sexually active, they should get a test for syphilis. And so what our guidelines say is that we should be screening all sexually active people aged 15 to 44 for syphilis in counties where primary and secondary syphilis rates are above 4.6 per 100,000 for reproductive age females. And so importantly, this includes 76% of the US population, and that's based on 2022 data. 2, we need to screen people with increased risk of syphilis exposure. So that includes people with a history of incarceration. That includes people with a history of other STIs. That includes anyone for whom that you are sending off STI testing. That should include syphilis testing. And then, as you all know better than any audience I've probably ever talked with, we need to be taking comprehensive social and sexual histories. I feel almost silly sharing resources about how to do that with y'all. But let's think a little bit about how to know if you live in a county that is above that 4.6 per 100,000 primary and secondary syphilis cases among reproductive age females. I think most of us know if we live in a place with a lot of syphilis, and frankly, that is most of us, period. But if you're unsure, you can either use this QR code or you can just search the web for CDC STI Atlas. Again, CDC STI Atlas, and you can find out your exact rate in your county. And then our second strategy was screening and treating people who are pregnant. So all pregnant people should be tested for syphilis early in pregnancy, which we know. And for a long time, we've recommended screening for syphilis at every first prenatal care visit. But what we are talking about more aggressively now is considering screening and treatment for syphilis at the time of pregnancy confirmation if someone has not yet established prenatal care or if follow-up might be difficult for them. The other thing that we can think about in that context is that if you have somebody in front of you who is pregnant or is trying to get pregnant and has risk factors for poor follow-up, it's very reasonable to use point of care testing to treat them empirically and then follow up serologic results to confirm your diagnosis and treatment plan. Our second part of the strategy is that at 28 weeks and at delivery, we should also be screening people with increased risk for syphilis exposure, partners with increased risk, or people who live in a high morbidity area per that prior CDC STI Atlas metric. And so there are some risk factors listed here that indicate a need for additional screening. Number 3, all people delivering a stillborn infant need to be screened for syphilis. Number 4, we need to prioritize treating people who are pregnant with benzathine penicillin G as needed. And Nellie talked about that new medication, that extanceline that's being temporarily imported to address the benzathine penicillin G shortage in the United States. And I just want to reinforce that that medication called extanceline is absolutely an option for people who are pregnant. Both ACOG and the Society for Maternal and Fetal Medicine have issued guidance to that point. And then 5, we need to be testing and treating the partners of people who are pregnant. And then I also want to reinforce that because of the rising rates of congenital syphilis, a lot of jurisdictions have instituted mandatory screening and different policies. So it's important to be aware of what the rules are in the jurisdiction where you live and work. And then here's that medicine called extanceline. So as we know, we have this big shortage, which has caused huge headaches for all of us. And what this means is 2 things. 1, we are prioritizing the vicillin or benzathine penicillin G, including the option for extanceline for people who are pregnant. And 2, if you need to prioritize it and you don't have a big enough supply of benzathine penicillin G, you can use doxycycline to treat people who are not pregnant with, if they have syphilis. And so here's that information on that extanceline. I know the name, it's a French name, so it's hard to interpret. So I thought I wanted to include it here for y'all. And then our third strategy, expanding screening in non-traditional venues. And so I love this strategy, and the idea here is that any healthcare encounter during pregnancy is an opportunity to prevent congenital syphilis. So we need to be implementing routine screening where people seek and receive care services. This includes in jails, emergency departments, urgent cares, syringe service programs, and other programs that work with people with substance use, homeless shelters and other homeless-related services, and then maternal child health programs, birthing centers, midwifery services, and doulas. And then as I spoke about before, we need to encourage people in these settings in particular to implement those rapid point-of-care syphilis tests when loss to follow-up is a concern. And we will be coming out with guidance soon from the task force about point-of-care testing clinical considerations. And then our last strategy, and this is why we're all here today and why we're so excited to have you on board in the fight against syphilis, is we need to be doing more education, training, and surveillance about syphilis. We need to be talking about syphilis and talking about healthy sex and healthy pregnancies. So we at CDC have active syphilis and congenital syphilis surveillance in all 59 jurisdictions in the United States to identify trends and missed opportunities. I encourage everyone to be aware of the trends and missed opportunities in your local community, and this can really help you identify the ways that you can be addressing congenital syphilis in your communities. 2, we need to educate and train clinicians to screen, diagnose, and treat people with syphilis, and I'm going to talk about a few resources to do that in just a minute. 3, we need to educate people who are pregnant about the risk to their pregnancy and baby if syphilis is left untreated. And what we know is that people are hesitant to seek care for syphilis, and that has a lot to do with some of the things I talked about at the beginning of this talk about the deep-seated mistrust in the medical and public health establishment in the United States. And we need to acknowledge that. We need to acknowledge the disparities in health that we see, in particular in syphilis, and we need to talk with our patients about it so that they understand the importance of getting treatment for syphilis. And as part of that, number 4, we need to educate the general public about the rise in syphilis and the importance of getting tested and treated. And so, like Nellie, all of my friends know all I ever want to talk about is syphilis. And I think at this point they figured out that syphilis is back. But we all need to be doing that as part of our strategy to combat syphilis and congenital syphilis. And so we need to be embedding syphilis education and awareness into our pre-existing programs and best practices. This includes educating and equipping local community health workers and doulas, as well as other trusted members of the community with syphilis information so they can share it with community members and advocate for testing and treatment. We need to integrate syphilis screening and treatment services into existing health programs, and many of you are affiliated with these. And then we need to be leveraging our social media platforms to promote syphilis awareness and prompt people to get tested. We also need to be conducting outreach and setting up mobile clinics to offer that on-site testing and treatment to those who can't access routine health services. And we've seen a lot of really cool and innovative strategies to bring the care to people so that they can get the testing and treatment for syphilis that they need. And then including syphilis materials in any toolkits that are geared around sexual health to clinicians and the public. So here are these great resources. These are just my 4 favorites. So you can take screenshots. So of course, because I'm CDC and I work for the Division of STD Prevention, I have to start by telling you to get the new updated 2021 STI Treatment Guideline app if you don't have it already. You can just go to your mobile phone's app store and search CDC STI and it pops right up. It's pretty easy to download. I find it pretty reasonable to use and it's free, so it could be worse. 2, a lot of people don't know about the National Network for STD Clinical Prevention Training Centers. They are a phenomenal resource, and they offer things like the National STD Curriculum, which is also a free resource that offers CME, and it is great for you and all of your learners. I find the modules to be really easy to track through, and they really can, people at different learning levels can learn a lot from them. I'll also mention that the National Network of STD Clinical Prevention Training Centers, which we call the NNPTCs, are also a great resource if you want local talks about syphilis in your community. So if you have some sort of forum where you think a presentation about syphilis would be beneficial, you can contact the NNPTCs and they would love to work with you. And the nice thing is that they are located all over the country, so they can provide that regional and local context to help understand your situation and allow for implementation of strategies that are best suited to your environment. And then if you are a clinician or if you know a clinician who is struggling with an STI question of any nature, but especially syphilis, and they love questions about people who are pregnant, which is usually not the case for clinical consultations, you can always reach out to the STD-CCN or STD Clinical Consultation Network. And it's at this website in the lower left-hand corner. It is, again, free. And they will get back to you in 1 to 5 business days, and it's usually 1 business day with an answer to your question. And so the way I think about this STD CCN service is that when I get a result for a syphilis test in my inbox, and if I don't know what to do with it, then these are the folks to call, and they'll get you an answer and help you to take care of your patient. And that's it. We did perfectly. So we have 20 minutes for questions and answers, and we're really excited to take those. Carol Johnson, I had a question about, are there any moves to establish free universal prenatal care? It would increase testing and treatment for the most vulnerable pregnant people with syphilis. And I agree with you. And I think, Medicaid is the option that we use to kind of address this conundrum in the United States, which has its challenges and certainly its limitations, which I'm well aware of as a clinician who still delivers babies. But that is our current strategy. I do agree with you that establishing a free, more accessible universal prenatal care option would address a lot of our issues, but I think that will take years to happen, and I worry about what will happen as far as syphilis in the interim. Someone put in, how can we get more clinicians to test and treat for syphilis, congenital syphilis in the emergency department? And I love that question. And so as part of the National Task Force, we've been working with the American College of Emergency Physicians, or ASEP, to think about how to address exactly that point. I will tell you that the main issue that emergency department clinicians have with testing and treating for syphilis is that they are using serologic tests that take a couple of days to come back. And as you know, emergency departments are not set up to have easy follow-up in a couple of days for test results. And so that is the issue that needs to be addressed in emergency departments. And I think one of the strategies to do so is, of course, the rapid point of care tests. So if a clinician in an emergency room has a patient in front of them who has not previously been treated for syphilis, they can send off a rapid test, get that result within an hour, and then empirically treat the patient while also following up their serologic results to make sure that the diagnosis was accurate and to inform their future treatment plan. And two is that we need to be working with connecting our emergency departments with our local health departments, because the health departments are designed to help follow up syphilis and syphilis test results, and they can help to track people down, which is often the concern I hear from emergency medicine clinicians. And then I see a question. Go ahead, Nellie.
Okay,
yeah, please do.
I'll just add to the emergency department piece as well is another thing to think through is if there's innovative things happening out there. I know at CROI, and I was frantically trying to find the block that was posted, but CROI is like the, don't hold me to the acronym, but it's where you learn about a lot of innovation that's happening in the HIV space. Syphilis was a topic there as well. And in Chicago, they're doing a very innovative model with emergency departments. So that's one thing that I can share the resource with Allison and Lynn later to share with you all. Another one is we've heard in North Carolina where emergency departments are testing really for syphilis, but the follow-up that's needed, there's a lot of burden on the emergency physicians. So they're tapping in, and I'm a pharmacist by training, they're clinical pharmacists to do certain follow-up. So just trying to think broader about how much are we putting on our physicians' plate? Is there something, or are there other healthcare workforce that we're not tapping into? And that's something the task force is also looking into to see where are the various factors, are EMTs, paramedics, pharmacists, nurses, where can we leverage all of healthcare providers to the top of their licensure and see if there are innovative things happening there as well. Public health nurses, that's another one.
I totally agree. And I agree with you, Trista, in the chat that we need to be working with public health nurses in partnership more. It's such a great resource. And I will say, John White has another really good question. John says that over here in the UK, our syphilis rates are also rising, but not yet seeing such high rates of congenital syphilis, which I think is an epidemiologic finding that I find very interesting. And I've been thinking a lot about that with my friends who are also in the UK. But to get to your question, you're saying that a majority of syphilis screening now takes place in the UK via online postal self-sampling services that are linked to public sexual health clinics. And do we think that that strategy would also work in the United States? And we're absolutely exploring that strategy. And there are a lot of new innovative ways to test for syphilis. There's a cool study that is affiliated with an institution that I used to work with called I Want the Kit, that is doing things through the mail to test. And we just need to think more about the sensitivity and specificity in the context of those tests, in the context of our US population, and who they might work best for. But I absolutely agree that that is a strategy that we need to be thinking about. And then I will just echo what I'm seeing in the chat. Community health workers are just such an underutilized, phenomenal resource in the United States. I include community health workers and health educators and doulas in that group. I think that medical assistants are also very much trusted messengers in their communities. And we need to be working with all of those folks in partnership. We're connected with a lot of organizations to help do talks like this about syphilis, but if there's a specific group with which you are affiliated who would benefit from a talk like this, you're welcome to reach out to Nellie and I, or to those National Network of STD Clinical Prevention Training Centers at NNPTCs, and they are happy to do talks like this to help make sure that we have the full team that we need to address syphilis and congenital syphilis in the United States. Go ahead, Nellie, anything to add to that?
No, I am thinking through, as a patient, when I walk in to my OBGYN or primary care doctor, the medical assistants, I mean, these are the first people you interact with. Sometimes they know, what's your problem? Why are you coming in today? I mean, just everybody that really touches that touches a patient, we should try and really bring them in, focus on this issue. So great information in the chat, community health workers.
Yeah,
Yes.
absolutely. While we're waiting for more questions via the chat and the Q&A, I will go through a few more best practices since you guys are giving us a little bit of extra time, if that's okay with everyone. I'm still watching the chat and the Q&A, and somebody jump in and interrupt me if you want to head it in a different direction. But we have these great information on best practices that we have found from the various jurisdictions with whom we work as part of CDC's work and also part of the National Syphilis Task Force. And so a few of these I thought would be helpful to mention to this group. So in Colorado, they're doing really phenomenal work around field delivery of medication, so that benzathine penicillin G to patients and their partners in their homes. One of the limits, obviously, with that first-line standard of care medication for syphilis is that it's an intramuscular injection. And so it does require more work to think about how to get that to people. And in San Francisco, they have this great project called Team Lily that offers wraparound services for people who are pregnant and experiencing homelessness, substance use, intimate partner violence, incarceration, and mental illness. And they provide a lot of support around getting appropriate syphilis screening and treatment. I will say that's a big ticket money investment, but that is phenomenal work that can certainly be emulated across the country. And then in Florida and California, to our question that we had earlier, they're working on expanding routine opt-out syphilis testing in emergency departments, which I think is a really interesting and promising idea for addressing syphilis and congenital syphilis. And then I'll mention, yeah, please go ahead.
No, I was going to say do the next slide too, so it's perfect.
Excellent. So and in North Carolina, they are working on implementing that rapid point of care syphilis testing among reproductive age women in their family planning, maternal and child health clinics, community health centers, and syringe exchange sites, like I talked about as part of my presentation. So this is a really nice model for doing that if that's something that would work for your community. Baltimore is doing something similar. So their family planning program is offering those on-site STI services at a substance use treatment program, which I find just to be such a really innovative strategy that's looking at their local data, understanding that substance use is a major risk factor for preventing congenital syphilis in their community, and then implementing a strategy to address it. And then in Philadelphia, the STD program collaborates with community partners, including syringe service programs, and other programs that serve vulnerable populations, to have this really cool women's night out to provide STI and HIV screening, as well as education, testing, condoms, and things like that, which I just find to be a great strategy, especially as someone who, I did all of those talks when I was a college student. I was the one who always did all the condom education in our local community, so this really resonates with me. And then I see a question from Elizabeth Alvey in the chat. In our area, we're getting a lot of pushback from the local hospitals not testing due to lack of symptoms. How to address this issue better despite talks? I mean, I hear you, Elizabeth. And I think, I can't say it enough, but syphilis is just hard. So between the complicated tests, the intramuscular treatment that's on shortage, and the existence of latent stages of infection, it's really difficult. And so I absolutely think that communication strategies are the ticket, but then, you really have to meet with people to understand, what is their hang up, because a lot of people, they don't understand the long-term implications of tertiary syphilis. So that includes cardiovascular problems, especially impacting the aorta. It includes dementia, paralysis, kind of all those things, as well as those weird gummas, those skin and soft tissue lesions that we saw from textbooks that often affect the nose and the genital area. And they don't understand those, and that even if somebody has a late infection, they could develop those terrible sequelae. And they don't understand that even somebody with a latent stage of infection during pregnancy can pass that to the fetus and result in terrible congenital syphilis-related outcomes. So I think oftentimes if you understand that rub point and you can help clarify what their issue is, and it requires, personal relationships as well as really listening to what people are saying, that can help move the needle. Because I agree with you that, these talks can only do so much. And I think a lot of times it comes down to those personal relationships and understanding a specific person's concerns. And then we have a couple of questions about rapid point of care tests. And so, Nellie, do you want to talk a little bit about the clinical considerations timeline and what's coming out? And I can talk a little bit more specifically about the tests.
Yes, absolutely. So the task force has been working on point of care testing considerations. It's been when we went out to really ask our jurisdictions and healthcare providers, what is it that you really need from the task force, which would be a question I ask of you all as well. Please feel free to type it in the chat or the Q&A. But one of the things that came up is we do know point of care tests are out there. Like, how can we be effective? How can we use them? What instances would you recommend using them in? So that's something that the task force has been working on for a while. They're coming out soon. I don't have a specific timeline for you, but they are in the final stages of being drafted right now. But we are coming out with those. It will have the considerations for folks, things that are included in there are missed opportunities. Where would you be using point of care tests? Where would they be most useful? What are the advantages? What are the settings that you may consider for point of care tests? When would you make sure that you're using the lab-based versus point of care tests? And obviously, sometimes you want to do both, some instances you want to do both. It will have the sensitivity, specificity data, which I think, Kate, if you have access to some of that information right now, we can share with you. But just managing, what does it really look like? Syphilis is complicated. Interpretation of labs can be complicated as well. So making sure that we're providing those resources. So soon, the point of care testing considerations document will be coming out, and we will definitely keep you posted. Kate, to you. I'll try to find the data if you don't have it handy.
Oh, that's good. I will say Indian Health Service already has available a lot of really great protocols around implementing rapid point of care testing. So if you just search Indian Health Service, syphilis, point of care testing, all that information will pop up. And the issue that Jill Stoops is pointing to in the chat, and the reason why it's difficult to give you sensitivity and specificity information about rapid point of care tests is because they really have to be used in the right population. And so there are two rapid tests that are currently available in the United States. One is called Syphilis Health Check, and one is called ChemBio. Syphilis Health Check test is just for syphilis. ChemBio is for syphilis and for HIV. Both tests, the syphilis component is just a treponemal test. And so treponemal tests, the way they work is that they are testing for specific things related to the treponemal infection, and they will stay positive for life in about 85% of people, even after treatment. And so what that means is that if somebody has already been treated for syphilis and they get a treponemal test, either through a serologic screen or through a rapid test, it has an 85% chance of coming back positive just as a reflection of their prior infection. So it's those non-treponemal tests that help us to assess for active infection, which is the point that Jill is making in the chat. And what that means is that if I have a population of people in front of me who has a low incidence of having previously treated syphilis, then a rapid test is a reasonable option as a first-line screening mechanism and for empiric diagnosis and treatment to be followed up by the serologic testing. And so populations whom that's often the case for are populations of people who are pregnant and most populations of reproductive age women, but not all. Because the majority of syphilis testing and treatment historically in the United States has occurred among populations of men with an emphasis on populations of men who have sex with men. And so, if you have a population of people who hasn't had a lot of syphilis testing and treatment before, it's a great option and your false positive results are going to be a lot lower. And then if you have a population who's had a ton of syphilis testing and treatment in the past, the rapid testings might not be as good of an option. And then I see, Jill, your fascinating comments in this chat. You're saying that, your clinic has had patients who have never had past syphilis infection testing and all had past syphilis infection test positive with that test, and all their serologic tests were also negative. And so you can also absolutely have false positives for other reasons. And I will say that the sensitivity also is not as good for people who have lower titer levels for the rapid tests. And so they certainly serve a purpose, but the way that I think about my rapid point of care tests is that if I have a patient in front of me and if they have never previously been treated for syphilis and I either cannot perform a phlebotomy draw because I'm not in a place that can do that, or they are a person who has substance use and they have no good veins, then a rapid test is a great option because I don't have any other way to take care of that patient. But if I'm in a place where I do have a phlebotomy draw option, and if it's a patient who I'm concerned they will not follow up for treatment, or if I'm not in a setting where follow-up is ever possible, then it's very reasonable to get your phlebotomy draw with your serologic testing results and to empirically diagnose and treat based on that rapid point of care test result. And then you can call the patient if you have the capacity to do so to tell them if their result on their serologic testing indicated a different result than from that point of care test. Does that all make sense, Nellie? Do you have anything else to add?
No, I think you covered it all, and I'm going to try and find the protocol that you mentioned for the point of care test that's already available with IHS. So try and put a link in there.
Okay. We can send that out maybe through Allison in our follow-up emails too. And I sent all the links that I presented. I also sent over to Allison, and so she'll send those out to y'all with the PDF of the slides.
Kate and Nellie, we have just a few minutes left of our time together during this webinar. And so I really want to ask you guys, you've presented so much helpful information, and I think everybody on this call really wants to know how they can do their part in lowering syphilis rates. So what are some things that you think that community members, researchers, clinicians, healthcare providers, what is it that we can all do to really play our role, play our part in lowering these infections back to those levels that we saw in the early 2000s?
I can start off awareness. If you are in your regular community, just increase awareness. We're talking to your providers, talking about awareness. Awareness is a huge gap for us. Just public awareness, provider awareness is another big one. If you have opportunities for us where you think providers, it might be very helpful for them to hear from us, hear directly from clinicians, or if they want to hear from those more boots on the ground approaches, and then PTC is a resource that Kate shared. That's a big one for me because we heard that that's a huge gap, awareness that syphilis is back. But that's, if anything, I want you to remember, just go out and try to increase awareness about it is my number one ask. Kate?
And I will just say syphilis is hard. I mean, we all are aware of that. And I think don't be intimidated by the hard stuff, which I know you're not because you're all people who are interested in talking to strangers about sex. So you are up for the challenge. And we're excited about that and to partner with you. So we have tons of great resources out there and please use them. There's no need to reinvent the wheel. And then the second thing and the last thing I'll say is that, local context is of critical importance. We see very different things with syphilis in different parts of the country and even within the same state. I live in Atlanta and across Georgia, we see different risk factors for syphilis and congenital syphilis. And we need to be following our local epidemiology, aware of our local epidemiology, and then working with partners to address those tension points that are making it so that syphilis is spreading.
I was muted, so I still haven't figured out to unmute myself even during webinars. But Kate and Nellie, thank y'all so much for presenting today. This was incredibly helpful information. John says that he hopes to see everyone at the NCSD conference. I also just want to highlight that the 2024 STI Prevention Conference is in September, and it will be in Atlanta this year. And it is the first time that this person will be back in person since COVID started. So I am incredibly excited for that. This webinar has been recorded. We will send out the recording along with Kate and Nellie's slides later this week. And if you have any questions, always feel free to reach out to us at AVAC or at ASHA or our wonderful colleagues, Kate and Nellie, as they provided their contact information earlier. So thank you, everyone, and I hope you have a great rest of your afternoons.
Happy STI Awareness Week, all. Bye.